Greetings and welcome to Bombay Orthopedic Society Basic Spine course. I am Dr. Ayush Sharma. I am one of the conveners of this course, and today I will be talking on the role of minimally invasive spine surgery in thoracolumbar spine fracture trauma. So, this was a 32-year male who presented with history of significant trauma, and he presented to us with neurological deficit. With neurological deficit was AISD, and as you can see, there is a thoracolumbar fracture at L2. You can see that the body has it's like a burst fracture with significant retropulsion at L2, and this is the CT scan. You can see again showing that there is a canal compression. And as they say, there are many ways to skin a cat, and there is the option of doing a laminectomy, doing a long fixation here, and that is absolutely fine. And I have no issues with that. But see, he was a 32-year-old male, and we thought maybe why not give him a option of minimally invasive approach, and he sort of agreed with us, and this is what we did. We did a short segment fixation, and we included the index fracture vertebrae in the fixation, and I think that is very very important, especially when you're going for a short segment MIS fixation. And look at this post-operative CT scan. You can see we have got a decent decompression of the canal just by getting the ligamentotaxis and indirect decompression. And this is the MRI, this is the pre-op. You can see the retropulsion, and you look at the MRI, post-operative MRI, and look at the CT. You can see that there is a decent amount of canal clearance, and that is what the MIS approach allows you. Even if you have not done a decompression, just by getting that fragment in the place, because this is how it was the moment you put the screws and got your posterior ligament taxis, this is what happens. So the retropulsion fragment just goes anterior, and you get that canal canal decompression. You can see the fracture here, but but the whole lamina, the posterior element, the spinous process, everything is intact. But you have got what you wanted to do in these cases. And this is 6 months follow up, and you can see a good fusion, bony fusion, good alignment, and this is the neurological recovery of the patient. This is his walking video. He sort of completely recovered neurologically as well. And this was another case, a 28-year female. She had a significant cardiac condition, which is, as we know, tetralogy of Fallot. So, sort of, she was unfit for a general surgery, general anesthesia. And as you can see, there's a fracture line going through the pedicle, complete fracture. And sort of, we discussed with her all the pros and cons of conservative surgery. And she's 28-year old, and she opted for a minimally invasive spine surgery, and we could do this under sedation with local anesthesia, and this is what we could achieve. Again, a MIS approach, she was able to mobilize within the next 24 hours, and this is 6 months follow-up CT showing good fusion and good realignment of the spine. Another a 45-year female, again a thoracolumbar junctional fracture, again a MIS fixation was done, and this is the post-op MRI, again demonstrating a good indirect decompression, and this is the follow-up X-ray, and you can see this is how it was a complete minimally invasive spine surgery. There is some small scar dots, that is all you see when you fix them in minimally invasive option. So why MIS? So most of these cases, if you see, they had some amount of retropulsion, and we have, again, you have to be very very selective when you choose these cases. Most of the time, what we choose is ASIA D and E, ASIA, and we, if patient is ASIA B or C, that is the time we do offer them decompression. But in cases where we have ASIA D or ASIA E, with some amount of retropulsion, we do go for MIS fixation, because these all these patient, all they need is the stretching of the posterior tension band, and you can get away most of the realignment of the spine. You can get the correction of the angular deformity, and the moment you get that, the retropulsion fragment just comes back, and that is what we just showed you in the post-operative MRI and CT scan. So understand this. If you're trying to achieve the same thing with open surgery, this is how it will be, because you need to really strip off all the muscle and the posterior element. While in MIS, you are using the percutaneous screws. So it is much better to use the intact posterior tension band and the posterior muscle fascia to get the ligamento-taxis in direct decompression. And of course, it's much more cosmetic. They have less blood loss. The chances of complication related to the spine surgery is slightly less in MIS fixation. So that's why we do go for MIS in these cases. Again, this is very, very important to understand. That one of the criteria which you must follow if you're doing a only fixation, percutaneous fixation, without indirect decompression, and without a direct decompression, the PCL should be intact. If the posterior tension band is not intact, then your ligamento-taxis and indirect decompression does not work. So if you put it in the classification for A1, A2, A3, B1, you can use this ligamento-taxis principle and percutaneous MIS fixation. But anything beyond B2, B3, you need to be careful, because then if you because your posterior tension band and PCL is gone, this principle is not likely to work, and you need to think of maybe a long segment fixation, adding a direct decompression, and all those things. So you have, when you're using these MIS fixation in this traumatic case, the case selection is very, very important. Now look at a completely different entity. Again, a thoracolumbar fracture, but this time it's a osteoporotic thoracolumbar fracture, and you see there is a retropulsion again, and there is a big void anteriorly. Can we use the same principles here? Of course, you can use the same principles here, but you need to slightly modify them. And you can see there's a retropulsion and there's a big cumulus lesion anteriorly. This is what we did. We use the same principles which we did use earlier for the traumatic cases, but here we added an anterior column support in terms of vertebroplasty. This is what we call as cement augmented vertebroplasty, because if you just put the screws and you don't augment or strengthen the anterior column, the whole construct is likely to fail. And this is what, again, the post-op CT showing good cement augmentation and good indirect decompression in terms of canal clearance. Another case, there's osteoporotic compression fracture with AISD. Again, we use the same principles of cement augmentation and vertebroplasty. Another patient of compression fracture, but here the DEXA was not that bad, and so we didn't use the cement because there's no anterior void to be filled in. And again, look at the canal decompression, the indirect decompression of the canal just by fixing the percutaneously. And you can see there is almost 70 to 80% canal clearance in the post-op CT. And this is one of our latest case, is significant kyphotic deformity with any osteoporotic condition. And we used cement augmentation in all the cases. And again, cement augmented vertebroplasty, that is what we call it. So this is just has been accepted as a technical note of what we call a cement augmented MIS screw vertebroplasty. So here what you do is you put the screws and you use this special screws which are fenestrated screws, and then we put this cannulas which goes inside the screw and then fill them with cement. So basically the advantage is, because the cement, because the screw holes are only in the anterior part of the screws, so the chances of posterior back out of the cement becomes very, very less. And I think it is could be a very good option, especially in these osteoporotic cases. and it allows you indirect decompression, it allows you cement augmentation, and it allows you anterior structural support. So this is what is some of the cases and some of the things which we do when it comes to thoracolumbar fractures. But my take home message will be patient selection and good surgical technique remains the most critical factor in these cases when it comes to the patient outcome. So most important is to select the right patient when you're choosing for a MIS option. PCL integrity is very, very important if you're relying only on the ligamentaxis. MIS approach does have its advantages, like the way I showed you. It allows faster recovery, but it does come at a cost of more radiation to you as a surgeon, more radiation to the patient, and it does have a steeper learning curve. So choose wisely, choose what works best in your hand. Thank you so much.